Yes, so my name is Ajay Choudhri. I'd like to thank GE and Mini.com for putting this together. I am chairman of radiology at Capitol Health, which is a hospital system located in central New Jersey. It represents about 450 beds. We are a not-for-profit organization that provides tertiary level care at the community level. So we have APEX programs in neuroscience, trauma, cancer, and heart and vascular disease. So that's spread across 2 hospitals. So we manage 2 busy ERs. And in about 2008, 2009, we started our comprehensive stroke center and neuroscience program. Beginning that early in the stroke, in neuroscience with stroke thrombectomy and interventional neuroradiology, we had a lot of challenges, and we had a flood of patients, a ton of transfers from outside institutions, and we had patients coming from all over. So our institution right now has a stroke ambulance. It has 4 portable CTs, obviously has CT scanners in the ER and in the hospital, and then a whole slew of MRIs. So our neuroscience program grew fairly rapidly, and we realized that managing all these outside transfers, that there was a lot of heterogeneous interpretation of scans from outside hospitals, mainly because they have varying degrees of expertise given their size and their scope. So building our program, we're a subspecialized group. We're 16 radiologists, and we are all C-acute in neuro. Anyone who reads neuro in our institution is C-acute. So we have a slightly more higher degree of expertise than, say, some of our community transfer hospitals. So the company MaxQ has a product that we have implemented that operates on inbound CT scans for bleed detection. So its first tier of its product addresses a problem for bleed detection. So to give you an example of how things work here, if somebody comes in with acute stroke symptoms and is a stroke alert, the mandate for our institution is that there is a read delivered by a radiologist within 7 minutes. The most crucial part of that read is whether or not there is hemorrhage or not. Now, that's all well and good, but if you have 10 or 12 CTs waiting to be read, how do you triage what comes up first, what needs to be read right away? So the first part of Achipio, which is the algorithm that MaxQ provides us, is a triage algorithm. So it processes CT scans and will change the work list and move something with a bleed to the top of the list, number 1. Number 2, because we don't have the actual responsibility of residents, but we are staffing around the clock. We have time demands that make a big difference. So we implemented this algorithm, and the algorithm is not just triage; it's also detection and identification and annotation. Those are not FDA approved yet, so we don't have that in our production environment. But we use that in our research packs to see the status of the algorithm and that sort of thing. So the need that it really fulfilled was accurate and fast triage. The algorithm works very well because all it does is add a series into our CT scan and says, suspect bleed not suspected, and then changes the triage level of the scan. So that's a workflow optimization tool for detection, and the upcoming product will then identify what slice and where the bleed is, and identify and automate things like blood volume, how big the hematoma is, and things like that. So for an institution like us, where we were taking a large amount of transfers, we have 2 very busy ERs that, we do 100,000 ER visits. That makes a big difference because CT brains, for all different symptoms can provide a very different experience for patients, some of which may have a bleed and have different symptoms. So it's helped us on the triage level, on keeping up with patients who have bleeds. It's also helped us on the detection level. Most of my neuroradiologists are comfortable as it is as readers, but sometimes it's nice to have the second look. I think the best place this is going to help is helping at outside institutions that may not have neurorads and may have general radiologists, and very subtle subdural hematomas and things like that are flagged by the algorithm right away. So our our experience has been quite good. It works very well within our workflow. All it does is add a series. Before we even open the exam, it's already done its work. So from that standpoint, it's been a joy to integrate into our workflow, and now it's just part of our life. Like we don't even, it's not even foreign to our workflow.